Hi, everyone. We'll give it just a couple of minutes and allow people to continue joining the webinar, and we will get started shortly. Thanks for being here. Okay, I think we'll go ahead and get started. I know everyone's time is really valuable these days. We're in public health. It's a very busy time, and so I want to welcome everyone to our HepVu webinar today. We're really thrilled to have you all with us to talk about a really timely and important topic, which is harm reduction services in the time of COVID-19. I'm Heather Bradley, the project director for HepVu. I'm an assistant professor of epidemiology at the Georgia State University School of Public Health, and I'll be moderating the webinar today, and I'm joined by an excellent group of speakers who I will be introducing in just a few minutes. So before we get started with today's webinar, I just want to take a moment to recognize the powerful movement against racial injustice and inequality that's happening in our country right now. One of the really core tenets of HepVu and our sister site HaidsVu is to highlight racial disparities in hepatitis C and HIV infections, and to move policymakers and program managers and researchers like ourselves to action in addressing these disparities. So please know that we will continue to highlight racial disparities in our work at HepVu and to do what we can to support all of you who are on the front lines of fighting racial inequality. Next slide, please. So, I'm sorry, I shouldn't have said that. Back to the last one, thank you. The COVID-19 pandemic, as you all know, has really touched every corner of the globe and has had strong ripple effects on social, economic, and health issues. And of course, harm reduction services are no exception. And so today we're going to spend some time talking about harm reduction services that prevent infectious diseases like hepatitis C and HIV and overdose among people who inject drugs. We're going to start by describing the impact of the COVID-19 pandemic on harm reduction programs. And we're going to talk about identifying some strategies that promote continued access to these essential services. And then also we'll talk about a bit at the end about the long-term impact of COVID-19 on harm reduction programs, policy actions, and potential opportunities for integrated infectious disease response. Just a couple of housekeeping things. So we'll have time for Q&A and discussion with our panelists at the end of the webinar today. Please do enter your questions in the Q&A section. You'll see this at the bottom of your screen rather than the chat box, and we'll be keeping track of those questions, so you can feel free to type those as the webinar is ongoing, and we'll make sure to get to them at the end of the talks. Today's webinar will be recorded and will be available through our HepVu site, so please let your colleagues know that they can access the webinar on hepvu.org, even if they weren't able to make it today. And last, I want to just let everyone know that Dr. Ron Baldessari hosted an excellent webinar last week on the more general impacts of COVID-19 pandemic on hepatitis. And I would encourage any of you who weren't able to attend that webinar to check it out on our site as well. Okay, so we have a really excellent group of speakers lined up. I am personally really excited to hear from this group today. Together, they have expertise in harm reduction related research, program delivery, and policy. So we'll start today's webinar with Dr. Dawn Desjardins, who's the Associate Director for Infectious Disease Epidemiology and Theory Core at CEDAR, the Center for Drug Use and HIV Research, and also a professor at the NYU School of Global Public Health. So Dawn will talk specifically about some national research that he and colleagues recently published on the impact of the COVID-19 pandemic on syringe services programs. We'll then turn to Tyler Bartholomew, who's the Director of Research and Evaluation for the IDEA Exchange, which is the only SSP in the state of Florida. Tyler will give us some local insights from his work on the ground in Miami. And last, we'll hear from Daniel Raymond, who's the Deputy Director of Planning and Policy at the Harm Reduction Coalition. And Daniel will really round out our webinar by talking about longer-term policy and implementation issues for SSPs, including some opportunities that may grow out of COVID-19 related challenges that we're experiencing now. So with that, I will turn it over to Dr. Desjardins.
Hello, everyone. First, I want to report on a study that Sarah Glick, colleagues, and I did that has been published in AIDS and Behavior. The next slide, please. Okay. Syringe services program have really become the primary intervention point for many prevention and treatment services for people who use drugs. They're user-friendly, non-judgmental, have fairly good hours and good outreach. However, the COVID pandemic has greatly changed operations at most syringe service programs in the US and probably internationally. But in addition to the reduction in services, the pandemic may present an opportunity for some syringe service programs to expand services, to include COVID-19 screening, to link it to testing for COVID-19, and possibly policy adaptations to better serve persons who inject drugs in the future. Next slide, please. So we conducted a rapid mixed methods, qualitative and quantitative assessment of the initial response of US SSPs to the COVID pandemic. We wanted to quantify and characterize these changes and their potential impact on people who inject drugs. Next slide. Okay. The quantitative data were collected through the North American Syringe Exchange Network, and the data I'll be presenting were up through April 16th. We've continued that survey of SSPs in the US and expect to be analyzing the additional follow-up data soon. We additionally did qualitative interviews at SSPs in 5 hotspot cities: Detroit, New Orleans, New York City, Philadelphia, and Seattle, because we wanted to get contextual information about what was happening in places where COVID was a major problem. Next slide, please. In our survey of the 173 programs, we found that 43% reported a decrease in availability of services. So almost half had to reduce their services to some degree. 1/4 reported that they had to close one or more of their sites. Slightly over half are now prepackaging all supplies for participants to cut down on personal interaction and to maintain social distancing. Many increased The supplies given, typically giving 2 to 4 weeks worth of syringes and naloxone so that clients did not have to come back as frequently. And slightly over 1/4 reported that they're doing some screening for COVID-19 symptoms among their participants. Okay. Next slide, please. Okay, in our qualitative interviews, and again, remember these were conducted in real COVID hotspots, the program directors reported that they had really adapted their services to maximize the safety of their staff and participants, that they were trying to keep social distancing whenever possible. They were trying to use personal protective equipment such as gloves and masks whenever possible, although they did have some shortages. They also reported that the demand for SSB services, syringes, naloxone, remained very, very high, that there was no reduction at all in terms of the demand. Most of the programs reported that they were considered essential health services, so that they were allowed to operate even during the most severe COVID restrictions, but this was not always recognized. And in terms of changing their services, they prioritized syringe and naloxone distribution, while HIV and HCV testing were reduced, primarily because those do require close personal contact with the clients. And they also noted that they can provide COVID-19 related services, screening, referral, information on how to social distance, how to self-quarantine if needed, and how to obtain health care if needed. Okay. Next, actually skip on to the next one. We were also conducting a study of COVID effects globally in Europe, North America, and Israel. We had done a study of 8 sites that recently had HIV outbreaks among people who inject drugs. So we're particularly concerned about these sites because they have a recent history of high rates of HIV transmission, and there's a potential that they could have reemergence of those outbreaks. All of the sites reported restrictions starting in March 12th to the 27th. Services generally continued, but there were reductions in services and changes in operation. They had reduced or suspended in-person client visits, including reducing counseling and reducing new intakes. The OST services reported treatment relapses, and ART services reported some treatment interruptions and some adherence problems. Okay, next. Okay. They also reported difficulties of people who inject drugs in meeting just basic housing, food, and hygiene problems due to the severe economic challenges and the changes in drug supply. So some of the service responses were giving more take-home medication, providing syringes according to needs rather than scheduled, some moving to long-acting OST, more use of telehealth services, and providing food and shelter for homeless people who inject drugs. Internationally, they were not doing much screening for COVID-19, and there was one site that reported COVID-19 outbreaks among people who inject. If you could go back 2 slides. Okay, so overall, the COVID-19 pandemic has revealed an urgent and dramatic shift in critical prevention services for people who inject drugs. The consequences of COVID-19 have created opportunities for ingenuity and pointed a spotlight on the fortitude of these programs. They've emphasized the resiliency of the programs. Programs indicated a desire to retain some of these changes, such as larger distribution of syringes and naloxone after the COVID pandemic response ends. And overall, the programs did stress the importance of their connections to populations who are at environmental and structural risk factors for serious COVID sequelae, in addition to their problems with HIV, HCV, overdose, bacterial infections. So that COVID-19 is an additional problem for this highly vulnerable population. And the programs very much want to address this new problem for the population. Okay. Thank you.
Okay, thanks so much, Don. We are going to move on to Tyler Bartholomew now.
Perfect. Thank you, Heather. So today I'm going to talk to you guys about a little bit of a case study with just one SSP here in Florida. I'm going to talk about our operational changes and how we've integrated telehealth service delivery during this COVID-19 pandemic. Next slide. Just a quick disclosure, we receive Gilead Focus funding. They fund our HIV and hep-c testing and linkage to care services. Next slide. So as Heather pointed out, the Idea Exchange is the first legal syringe exchange program in the state of Florida. In 2016, the state of Florida passed the Infectious Disease Elimination Act, or IDEA, that authorized the University of Miami to open a pilot syringe service program in Miami-Dade County. Through a lot of effort, they passed the IDEA Act of 2019, which actually solidified our program no longer a pilot, and we're allowed to implement syringe exchange across the state of Florida, which was a huge win for harm reduction for the state. So our program offers a fixed and mobile one-for-one needle exchange, and that's by statute that we do one-for-one exchange. We have safe injection packs, nasal naloxone, HIV and hep-c testing on site, HCV RNA testing as well, and we have linkage to HIV care, hep-c care, and substance use treatment. So through May 2020, the Idea Exchange has served over 1,400 individuals. We've exchanged over 500,000 syringes, distributed 3,000 boxes of nasal naloxone, and administered nearly 2,500 HIV and hep-c tests. Next slide. So to give you guys a little bit more of a ground level perspective about what Dr. Desjardins was talking about with participants coming and asking for more supplies and syringe exchange programs, adapting to that. What we see here with our data from the Miami SSP is before COVID, we were pretty steady on the number of people who are coming and exchanging, and that's that orange line. And that blue line is the number of syringes per exchange. So we're fairly even and level across time before COVID, where that black line enters. And you can see those two lines begin to merge. And we see that the number of exchanges that we were doing at the SSP dipped, but the number of syringes that we're giving out per exchange was increasing. So showing that need for syringes and people planning ahead during the COVID pandemic. And we also changed our operating procedure to abide by the social distancing measures, and also all of our staff wore PPE, but we actually closed down our fixed site and had our staff members sit inside, and we had a little window in our trailer, kind of like a cafecito window for anyone who's been in Miami, to where we were actually doing this syringe exchange through that window. So we could see that our service delivery had drastically changed, but the amount of supplies that we were giving out was increasing after COVID. Next slide. One thing that Dr. Desjardins highlighted was the discontinuation of HIV and hep-c testing. We thought it was very important for us to get back because we had experienced that as well. We discontinued our HIV and hep-c testing, but we wanted to get back into doing our testing. So we established a protocol, a COVID protocol for our participants. Since the Idea Exchange sits in UHealth and Jackson Health System, we had guidance from our healthcare system talking about how to deal with COVID patients. We actually implemented COVID screening and testing on site at the syringe exchange program. So all this is done outside or through the exchange window, like I had said. The healthcare provider will wear PPE at all times, and we perform a COVID test, an HIV finger stick test, rapid test, and a hep-c antibody test concurrently. We have an entire protocol if patients are symptomatic, if patients test positive. We had, today we've tested over 31 people for COVID, and one was positive, and we had a rapid linkage to the hospital to get treatment for COVID. But we do have partnerships with the Homeless Trust in Miami and Love and Live Foundation, Love and Life Foundation, sorry, to help those individuals who are experiencing homelessness to do shelter in place and specific things like that. Next slide. So what we can see here with our HIV and hep-c testing, we're testing as many people as we could every week before COVID, but then as soon as we implemented that new protocol as far as discontinuation of our testing, we saw that testing was non-existent for that time frame. But when we implemented that new protocol, our testing infrastructure came back and we were able to start testing again, which was a big win for us. Next slide. So before COVID ever happened, the Idea Exchange in 2018 has started to move towards implementing telehealth services, particularly for HIV care. In our program, we had numerous acute HIV infections, and there was really no pathway for someone living with HIV who was experiencing homelessness, who was injecting drugs, living under the overpass to get into HIV care. So we've actually implemented an entire telehealth infrastructure around linkage to HIV care, which you guys can all see here. When a patient comes in, if they were to test positive, we actually can do a on-site Ryan White enrollment via telehealth with SFAN, South Florida AIDS Network, with a Ryan White case manager. They'll do all the paperwork over Zoom call. If the patient's deemed eligible, they sign all consent forms. The Idea team sends over the forms in the 1628 form to SFAN. And then what we've changed here is this end portion. Before COVID, the Idea linkage to care coordinator would escort that person to an HIV provider and pharmacy, and then the specialty pharmacy after for ART. But now that is done completely telehealth. So we actually are able to access via Zoom an HIV provider for that participant. And then that same day that patient can actually get on medication. Those medications are delivered directly to the exchange, and we are able to dispense those medications for them. So once those medications come on site, we have an entire medication management protocol as well through pill lockers, to where if people are living with HIV and experiencing homelessness, they can come and store their medication there on site. Next slide. Oh, perfect. So then and again, this also extends into those who are experiencing homelessness who might be using our mobile unit instead of our fixed site. So the process of how that works is the Idea team is notified of an appointment for HIV care. The team is dispatched to the field with an iPad and a hotspot, or the participant comes to the Idea Exchange fixed site for a Zoom meeting. So we actually can do this functionality on both our mobile unit and our fixed site at this point in time. The meet with an HIV provider, the prescription's written, there's an electronic prescription that's sent to the pharmacy, and then the medications again are delivered to the exchange. And one of the new capabilities during this COVID-19 pandemic, we were able to actually draw the labs in the field and send those off to the lab. Next slide. So just quick preliminary outcomes of our telehealth HIV care system. So since COVID-19, which we're going to constitute as March 31st, which we know it probably happened way before that. But 22 Idea Ryan White enrollments, and that's new or re-enrollments, because we know that those who are enrolled in Ryan White have to re-enroll after 6 months. All done via telehealth. We've had 18 HIV provider visits since March 31st. And currently we have 41 participants who are living with HIV on our medication management protocol at the Idea Exchange. Next slide. one of the cool capabilities that we had before COVID was we had a student-run free medical clinic every Thursday night from 4 to 8. Unfortunately, due to COVID-19, that had to be discontinued, and the medical students weren't allowed to come on to the campus. So instead, the medical students had developed an entire telehealth system to do their wound care assessments, to do Suboxone prescriptions, mental health counseling, general health check-ins, medication refills, and again, abscesses evaluations, which is huge. So this system was set up by our medical students, and the same system that we see with the HIV care. Next slide. So to give you guys just a little glimpse in the data for this telehealth portion for our medication-assisted treatment or medication for opioid use disorder, we had 32 IDEA clients request telehealth appointments. 22 of these requests were for medication for opioid use disorder. And today we have had 15 medication for opioid use disorder prescriptions sent to the pharmacy. We're working on collecting the data and getting the data to see if those prescriptions were picked up. And we're going to be doing an assessment on adherence for those individuals at 1 week follow-up to see how they're doing on their prescription. Next slide. Perfect. So just wanted a quick glimpse overview of what we're doing at IDEA Exchange to bring these specialty services on site during this crazy time of COVID. But I wanted to, again, thank the entire IDEA team, everyone who's doing all the hard work on the ground and doing everything for our participants, and those doc students who decided to open up this entire telehealth infrastructure for medication-assisted treatment. It's been amazing to work with these folks. So I just wanted to give them a quick shout out.
Thank you so much, Tyler. That is incredibly impressive work, and I appreciate you sharing it with our participants today. We will now turn to our final speaker, Daniel Raymond.
Thank you, Heather. Thanks everyone for joining us today. So to build off of what we've heard so far, I wanted to pull us more forward looking into what we can learn from what's been happening to what might happen in the future. And so in preparation for today, and in conversations with a lot of other people in the harm reduction field, I wanted to lay out 3 potential scenarios for syringe services programs in the COVID-19 era, by which I mean as an era that I think there's a general recognition that COVID-19 will be with us for a while. And so thinking about this long period, what possible shapes could it take? Next slide, please. So the first scenario that I wanted to describe a bit, I'm calling scenario 1 public health integration. So this would reflect something like a strengthened resolve or a renewed national commitment to investing in public health, which ushers in an expansion of syringe services programs as an essential component of the infrastructure. By which I mean delivery mechanism, not just for injection supplies and naloxone, but also for, as we've heard from Miami, for COVID-19 testing, education and referrals and linkages to healthcare, and potentially vaccine delivery once vaccine for COVID-19 starts to become a reality. And this is a scenario that would take place if there was a greater buy-in and appreciation to the essential roles that certain services programs are currently playing around drug user health. What we might hope to see under this scenario is state-level policy reforms, including states where there are still barriers to legal syringe access and the operation of syringe services programs. We might hope to see a dedicated federal funding stream. Right now, most programs are cobbling together funding from state and local government, some of which is drawn down from federal cooperative agreements or block grants, but not specifically dedicated for certain services programs, as well as private funding, individual donations. but that baseline kind of anchor of a dedicated federal funding stream has not yet materialized for certain services programs in a meaningful way. And then ultimately, we could hope under the public health integration scenario to see rapid growth of new programs in diverse settings. We have seen significant growth in new programs since 2015. We at National Harm Reduction Coalition estimate that there is somewhat in the range of 500 operational syringe services programs across the country. CDC has done some work and calculated based on looking at new hepatitis C infections among people under 30 as a proxy for where injection-related risk is happening, that to really make sure that syringe services programs are accessible for the entire population, that we would need to multiply that number by something like a factor of 5 and to get to something like 2,500 programs across the country. So if as a nation and as a society, we see COVID as an opportunity to double down on our commitment to public health in a way that recognizes syringe services programs as essential infrastructure, then I would hope that over the next 3 years, we would see some of these trends playing out. Next slide, please. So scenario 2 is what I'm calling retrenchment and reversal. There are no guarantees here about how the COVID-19 landscape is going to play out. And it's not at all unimaginable that recessionary pressures result in substantial state and local budget deficits that turn into significant cuts that hit syringe services programs. I also think that there's some questions about if we are going to be in a long COVID moment, what that looks like in terms of risk attribution and blame, especially for already stigmatized groups, whether those are immigrants, people, returning citizens, people who've been incarcerated, people who use drugs, people engaged in sex work. And so in this more pessimistic scenario, we're going to see some significant budget pressures that could lead to further program shrinkage or permanent closure. We could see scenarios where, as we're seeing now with increased COVID-19 case reporting in places like Texas and Florida, that there's going to be some polarization that leads to scapegoating and potential suspicion of people who use drugs as potential vectors for transmission. There's already been some discourse in epidemiology about figuring out who the super spreaders are, the people who are disproportionately responsible for a large number of new infections. And it's not clear if we're going to see people who use drugs scapegoated for that. And then the policy changes that we've also seen over the last 5 years, if we're in the midst of a broader polarization about the meaning and the value of public health, then the window of opportunity that we've seen that's most recently been driven by attention amongst policymakers to the opioid overdose epidemic could start to shrink. Next slide, please. So I also want to call attention to what I see as a third scenario, which I'm calling rethinking harm and safety. So this moment that we're in with the uprisings that we're seeing around the country, the debates and dialogues that Heather mentioned at the beginning, one of its concrete manifestations is advocacy pressures to defund police, with a call for rethinking broadly how we're talking about producing safety and addressing harms at the community level, whether that means better access to mental health services or violence interrupters, or shifting towards different mechanisms to transform what risk and safety look like. So if we pursue this road, I think that there's some potential consequences of that. I think that this dialogue is very consistent with deprioritizing or decriminalizing what we've seen over the last number of decades really, of heightened exposure to arrest and incarceration targeting people who use drugs, whether that's around drug possession, whether that's around loitering, whether that's around commercial sex work, or the range of ways that people who use drugs are scooped into our mass criminalization and mass incarceration system. There have been calls for transferring resources and responsibilities for different kinds of community problems away from the police and back to communities. And this may include drug-related problems, which law enforcement in the context of overdose has taken an outside role in being tasked with managing. And then finally, a potential expansion of grassroots harm reduction models that are more modeled off of the mutual aids networks that we've seen proliferating in the context of COVID-19 that are more directly accountable to communities for addressing equity, disparities, and historical injustices. Next slide, please. So I lay out these three scenarios, and I'm sketching them very broadly, and they're not limited, I think, in terms of the possibilities to which path we'll go down. They're not mutually exclusive. We might see a blend of all three to different degrees, and they might be evenly distributed across the country. So one city or state or community might take one path or emphasize one trajectory, another might emphasize a different one. But I think it's a good time for us to grapple with all of them and the opportunities that they present, as well as the risks, because I think each of them would call in their own way for a heightened degree of coordination, alignment, and advocacy. So I wanted to bring that future perspective into this conversation and offer both a sense of caution and a note of hope that how we learn from, listen to, and leverage this moment is likely to shape the landscape for certain services, programs, harm reduction, and people who use drugs for years to come. Thank you.
Thank you so much for those important insights, Daniel. That was very enlightening for me, and I'm sure for many of our attendees as well. So I will be joined now by our whole panel, and we'd like to open it up for questions. I have seen a few questions come in on via Q&A, and so let's go ahead and start with those. Tyler, I believe the first couple of questions are for you. One participant wanted to know which telehealth provider you're using for the IDEA clinic.
Sure. So we're very lucky at IDEA Exchange for our medical director, Dr. Hansel Tukes, who's been the driving force for harm reduction in Florida, to also be an HIV care physician. So he does a lot of those HIV provider visits, and his appointment is at Jackson HIV Clinic, and we also are partnered with University of Miami Health System to be able to provide this telehealth service at the exchange. So we have a growing network of HIV providers who are at University of Miami who are into harm reduction and into serving this community, who are providing telehealth services to our participants.
Okay, super. And then we had a question come in from Facebook Live. One of the Facebook Live viewers wanted to know if you might be willing to share your HIV, HCV, COVID testing protocol.
Oh, absolutely. If anyone is interested, they will be more than happy to share it with everyone.
Excellent. Great. So our next question is a data question. I think this is actually a good question for all of our panelists. So an attendee wanted to bring up the point that locally SSPs are collecting minimal data due to COVID, which seems to be bringing in more new clients. And so this attendee says that the SSPs in this country require a large amount of data collection for each participant's daily visit. To me, this felt like a barrier and was not allowing for an organic relationship to develop between participants and the SSP staff. The person goes on to say this data that we're collecting is not showing anything new. SSPs are already evidence-based programs. any suggestions for how to advocate for less data collection in the future. So Don, let's start with you.
Okay, actually, most SSPs nationally are not collecting much data now. They are collecting, visits and syringes out and naloxone out. But programs that used to do person-to-person interviews that would take 30 minutes or so to look at risk behavior, to look at homelessness, to look at unsafe sex and such, are basically not doing those interviews anymore. That there's sort of been almost a national and international proscription of doing face-to-face interviews because they typically are a high-risk situation of talking to somebody for 20, 30 minutes. So basically, both nationally and internationally, we're sort of flying blind as to what's happening. There's certainly a big concern that syringe sharing may increase. There's another big concern that social distancing is not really going to be feasible for most of the people who use drugs population. So that as soon as we can get back to the situation where we can do fairly extensive research, we can try to map out future directions. But right now we're really collecting operational data at best and do not have a great sense of what's happening with the people coming to exchanges.
Thank you. Daniel or Tyler, do you want to add anything to that?
Yeah, so a couple of things that a lot, but not all of the data collection mandates that we see in somewhat diverse forms across the country represent political mandates that to some degree or another, the state law authorizing a set of programs included some data and reporting requirements, or the conditionalities that state health departments tied to funding require those data collection points. And I think, I think there's two things that I'd like to kind of lift up. So one is that in this broader moment that we have an opportunity to look at some of the systems and structures that we've taken for granted and ask whether they were really serving the purpose that that ostensibly we use for rationalizing them. And we've seen that with some emergency policy changes around methadone and buprenorphine in particular, as something that I think a lot of people have waited or advocated for a long time, and to see in this moment of crisis, a pandemic, of emergency, that actually the sky is not falling, I think there's an important signal for us to be paying attention to. And I think the second piece is that this broader sense of whether what the relative benefits and costs of extensive data collection on a per individual, per transaction, program basis are generating meaningful engagement, meaningful information, and linked to strategy, is one that is going to be really necessary to revisit, because the other broader long-term moment we're in is a push at the federal level in the context of ending the HIV epidemic in particular, of scaling up prevention that works. So this is an excellent crossroads to think about what broader advocacy could look like, and I think that it needs to come from both local, state, and federal levels.
Great. We have a long list of questions coming in now, so we're going to go ahead and move on to the next. I'm so happy to see people engaging. Holly Hagan has a question for Daniel. She says, expansion of SSPs in the US has included a large number of programs that are not set up to meet the needs of people who inject drugs. For example, in Appalachia and New England, many new programs only operate 2 to 3 hours a week. And so her question is, how do we ensure that best practices for SSPs are part of any new programs?
Yeah, so I think, I'll keep this brief so we can get to as many questions as possible. My organization, the National Harm Reduction Coalition, and not us alone, there are other groups doing this, have been doing technical assistance for a number of years, including in those regions, to try to promote that. But I think from a systems level change perspective, technical assistance around best practices is necessary but not sufficient. The two other pieces that I'm feeling increasingly pulled towards is that one is about adequate funding, that it's better to have a program that's only open for 2 hours a week if that's all that you can afford than to not have a program at all. But I don't think that anybody's pretending that they are confident that that meets all the needs. So where there's resource bottlenecks, we're going to have bottlenecks in best practices. And then the third piece that I also think is important is really to conceptualize this at a systems level in terms of building out a robust ecosystem of different kinds of programs operating in different kinds of ways. So some of the smaller programs that might be more constrained, we're seeing emerge in rural health departments that might have some money or access to supplies, but don't have access to dedicated staffing. Coupling those programs with something that's operating on a more grassroots level or mutual aid basis brings in possibilities that different kinds of programs can meet different people in different places in that drug use continuum, and that collectively that ecosystem could fill in different kinds of gaps rather than having it rest all in the back of one specific kind of program that might be cash strapped or have operational constraints.
Okay, great. So Colleen Flanagan has a question that I think is probably best first directed to Tyler and with maybe a follow-up from Dawn. She asks whether there are any data showing that offering COVID testing increases the number of SSP clients. And I'd like to add just sort of a broader question to that, which is, how are the SSPs collecting data to document changes in services and strategies that worked or didn't work, so that we're able to look back on those data when the pandemic is finally over?
Yeah, absolutely. So I think to answer her question about is there any data showing offering COVID testing increasing the number of new SSP clients, I don't think that data is there yet. I think that's the next stage, is to see of those SSP sites that are doing COVID testing, if they're seeing increases in the amount of participant flow, the services being offered, which is something that we're interested in looking at, specifically at Idea SSP now that we are COVID testing and have the infrastructure data-wise to look at our service delivery and the number of exchanges we're doing. And we can stratify that by our mobile unit or a fixed site to look to see which of those modalities are actually increasing in their service delivery. So, and the second part of the question was?
Just a more general question about, how should harm reduction programs be thinking about data collection meant specifically to document effectiveness or ineffectiveness of strategies that they're rolling out to serve clients in a new way?
I mean, I think that's a tough question to see what exactly is working during this hectic time for all of these programs. Like, we're seeing that a decrease in services and operational hours, and then asking an SSP to collect this data regarding COVID testing. I know for us, we've just integrated into our RedCap system where we do some of our data capturing. But for those sites that don't have as robust data systems, I think that's a tall task to ask them to start collecting that data.
Sure.
I would add that
Could you speak to that?
Okay. I would add that there's a national study that has been proposed to look across a national sample of syringe exchange programs, see what they're doing, match that against standards like how many syringes are they able to get out, how much naloxone, how much testing. We're going to be in very, very bad shape if each program has to do trial and error learning by itself. So the purpose of this study would be to survey all of the programs, use common metrics to see what's working, and then feed that back to the field. So that there are people thinking about this, trying to get money to do the necessary research, because we don't really want to be in a situation where each program is doing trial and error learning without any systematic collection and analysis of the data.
Sure. And and those data can also be used to understand, changes in incidence of infectious diseases like hepatitis C and HIV that we may see happening. I think it's important to consider how we'll be able to explain those using data that we collect now. So Louisa Gilbert has a question that I think is directed toward Tyler, but anyone else feel free to chime in. And Louisa says, since the COVID-19 lockdown, have you seen racial disparities in who was able to access services, resources, and telehealth services? How are people without access to Wi-Fi or smartphones being reached? Are the data showing any differences in how harm reduction programs that serve primarily Black and Latinx populations are faring versus harm reduction programs that serve non-Latinx white communities?
Yeah, absolutely. So, I'm going to talk from experience at Idea Exchange. I think what we've tried to do is try to reach those racial and ethnic minority communities through our mobile unit services, and trying to go into those specific areas to make sure that those services are being delivered constantly to those individuals. As far as seeing differences in the telehealth and disparities across telehealth, I think that's an interesting question. And, again, getting the data and looking at that specifically is on our radar now to look at. But as far as people without access to Wi-Fi or smartphones, we have actually been able to use our mobile unit and go to where that person is and offer that low threshold, low barrier care as far as HIV may go, providing the tablet, providing the Wi-Fi. And if someone comes into the fix that, we have all those capabilities as well. So we're trying to take those more systematic barriers of not having access to smartphones and Wi-Fi by just bringing it to that client specifically.
In the national survey, we found a really great commitment from the programs to reach disadvantaged groups, to reduce inequities that are growing because of COVID, and relying upon word of mouth rather than just mobile phones or telehealth, that drug users are still an interconnected community. They talk to each other, particularly they're talking about where they can get drugs, where they can receive services, so that we can utilize those personal connections without having to rely upon any expensive technology.
That's an excellent point. So we have a couple of questions specifically about testing. So let me just sort of couple these. One is, and Tyler, you're sort of on the spot here. I think these are probably first directed toward you, and then let's have others jump in as well. One is, have you found it to be an issue in having your harm reduction clients to test for HIV and STDs? And if so, what strategies have you used to have them test? And the related question is that when you say you conduct labs in the field, do you mean street-based or van-based blood draws?
Absolutely. So as far as the offering of the testing, that's voluntary at this point. And again, like I said, it's implemented alongside our COVID testing. At Idea Exchange, we have, if a new person comes to enroll, we routinely screen for HIV and hepatitis C in an opt-out testing framework. So if someone is newly enrolling, we're offering COVID testing alongside the HIV and hep-c testing to do those. Anyone can decline doing an HIV test. We haven't seen any issues with people declining HIV tests, and that might be the amount of rapport that we have with our community for how they trust us. We do very routine HIV and hep-c screening at the Idea Exchange. And then as far as conducting labs out in the field, we have a mobile unit that's set up to do all those blood draws. So we're moving from even being able to do it in the field as far as, on the sidewalk drawing blood. But we're using the mobile unit and those services to get those blood draws.
Okay, and just one more follow-on question to that, actually, from Ron Valdeseri, who is also part of our HepVu team. And Ron is wondering why it might be that hepatitis C testing is less frequent than HIV testing, and is also curious about follow-up procedures for clients who have a positive hepatitis C test.
Who and all the questions today. So for us at Idea Exchange, I think what we see routinely across the board with SSPs is that the prevalence of hepatitis C is so much higher than it is for HIV in the United States. And for us, we've been operating for over 3.5 years now, who've been routinely screening. At this point in time, we're screening every 3 months, and we've already had so many HCV positives that we're not retesting them, right? So we're not testing them over again for an HCV rapid antibody test. So that's where I see the discrepancies in the HIV testing and the hep-c testing come from.
Yeah.
As far as, I'm sorry, go ahead.
If I can add to that,
Sure.
historically, it's been much easier to get HIV testing paid for than hepatitis C testing. So that has been the big historical reason why programs were doing so much more HIV testing than HCV testing. Another factor is that there's good oral fluid tests for HIV, and there's one fairly good one for HCV, but it's not licensed in the US. So particularly if you're thinking about trying to avoid contact with blood and such, it's really nice to have an oral test.
Absolutely. I think we're very fortunate at Idea Exchange to be part of the Gilead Focus Project, who supply all of our rapid HIV tests and all of our rapid HCV tests. And we are a completely anonymous program, so those tests are actually anonymous tests that we're completing at the Exchange.
Okay, that's great, and great context, Don. Thanks for adding that. So we have just a few minutes left, and the way I'd like to end is just to give each of our 3 panelists a moment to talk about what they see are opportunities for moving forward with the importance of harm reduction strategies that we're all working to implement in terms of programs and policy and research, depending on each of your focus areas. And if you want to use this as a time to call the community to action and let us know what we can do to help, that would be great. So Daniel, can we start with you?
Sure. Thanks, Heather. I'm going to name a couple of things. We have been doing a range of things at the National Harm Reduction Coalition as part of our response to COVID-19. That's included doing virtual office hours every other week. We've been gathering together a group of executive directors to talk about what they're seeing and how they're experiencing it. So I'd encourage people to check that out and plug into it. We have a master list of resources on our website, but we're also trying to amplify the role of harm reduction in this moment in various ways. We've been filming videos of some of the California programs and how they've been adapting that are on our YouTube channel. We've been trying to talk about this, get stories in the media, and we've been trying to amplify it as we work with our advocacy partners. So I think that this is going to be a good time to name not just the enduring importance of these programs, but that as we come out of this moment, I think that we're going to start to see that we've lost a lot of people due to overdose, that we have had a surge in new hepatitis C and HIV infections. We already have the overdose data. It's not clear when we'll see that for hepatitis C and HIV. But to continue to kind of sharpen the message that people who use drugs are a critical population, harm reduction is an essential strategy, that this is the time to double down on that.
Okay, thanks so much. Tyler?
Sure, I just want to, as far as service delivery goes, it's drastically changed during this COVID pandemic. And I just want to continue to highlight, the central harm reduction tenets of being compassionate. And sometimes, a participant comes in a program, the only interaction they have with an individual for the day is our staff. And it's hard in the time of social distancing to give that person a hug and being that warm contact to them, or even giving a smile because everyone's wearing a mask now. And that's going to be the foreseeable future moving forward, is that we're going to be having to do these social distancing measures. So for us, this COVID pandemic has drastically changed how we work with our participants. And I think that for the worse, for sure, for the worse, because we always want to give compassion and give that warm hug in a sense to our clients. So, you know, that's something that we're going to be focusing on moving forward.
Okay, excellent. And with just about a minute left, Don, we'll give you the last word.
I think there's a tremendous and overdue movement going on in the country to move away from law enforcement as a solution to all our social problems, that emphasizing law enforcement creates as many social problems as it solves. And I think in terms of services for people who use drugs, we need to build on that and use drug use as a prime example of something that should be a health issue, not a law enforcement issue. And within that health framework, the SSPs are really the front line of working with people who use drugs, providing services, and as Tyler mentioned, developing positive social relationships between service providers and people who use drugs. That it's not just giving people naloxone or syringes, it's developing a positive personal relationship that helps motivate people to move towards healthier lifestyles.
Excellent. I think that is really the perfect ending for our webinar today. We all really appreciate you being here and taking the time to talk about this timely topic. I know I learned a lot, and hopefully all of you did too. You can see here on the final slide how to connect with us at HepVu. You can email us at HepVu or info@hepvu.org. You can go to hepvu.org and of course follow us on our social media platforms. Again, just thank you so much for being here, and please check out the last week's webinar facilitated by Dr. Valdeseri as well, and we will be seeing you soon. Thanks so much.
Okay, goodbye.